Thanks very much, Kim. My mother wrote a lot of those introductory remarks, so I want to thank her for that. She still thinks she's just happy that I have a job, I think, at this particular point in time. So I'm going to talk a little bit about the Ottawa model. This will be one of the first times, it won't be the first time actually, that I've gone home in the same cab as the audience. But now, these days, we say we go home in the same Uber as the audience when the audience is small. So let's talk about smoking cessation. Of course, why do we care about this? Well, this is the reason that smoking gets all the attention in terms of interventions is that smoking will kill you, and so this was basically the premise of our research, that we need to start to do a better job actually assisting people to quit smoking, and that was kind of the genesis of our program. Now, I happen to work in a hospital, in an actual heart institute, where all we see all day long are patients who've got cardiovascular disease, and in fact, smoking is the most preventable cause of people coming to see us in the first place. And so our program really evolved out of a desire to initially just try to do a better job helping people that came into our hospital, help them to quit smoking. Just to give you a little bit of background, because I know not all of you are from Canada, some of you are, but Canada is a gigantic country, second largest landmass of any country in the world, and we have about 35 million people living there. Our smoking prevalence these days is around 16%, and that translates into somewhere between 5 and 5.5 million smokers that we still have. And of course, the reason that people are smoking today is not because they don't know that smoking is bad for them, because virtually every smoker knows that, but it's because of the addictive nature of smoking and tobacco. But it's also because smoking is a very highly conditioned behavior as well. People start to associate smoking with many other things in their life, and that therefore is the role of both counseling as well as pharmacotherapy in the treatment of tobacco addiction. So one of the other main premises of what we do is this idea that when people are exposed to healthcare environments, is this in fact a teachable moment? Is this a time when people's motivation to change might be higher than average? And in fact, we do find that when people come into the hospital, they suddenly find religion, they suddenly decide that smoking is something that they want to give up. And in fact, all we really set out to do was provide them an opportunity to do just that. Because again, when we ask people if they want to quit or not, virtually every smoker these days will say that they want to at least cut down the amount that they smoke, but many of them in fact want to quit. So the Ottawa model was kind of born out of that, and when we reviewed the literature and the evidence about what works in terms of helping people to quit, it really came down to we need to, first of all, be systematic about identifying who is even a smoker when it comes to the people that we may be dealing with. And interestingly, in the hospital setting, when we ask people, are you a smoker, some people will tell us that no, they're not a smoker because they quit on that day coming in the ambulance on the way to the hospital. So you have to be very specific about the way that you ask about smoking, otherwise you get not really good answers in terms of identifying who's actually a smoker. Of course, that needs to be documented in some cases, but all we wanted to do in a hospital setting was to provide a little bit of strategic advice to people, systematically use pharmacotherapies, and then engage people in long-term follow-up, because we know that smoking and smoking cessation are long-term challenges for people. This is not a one-night stand. This is something that this is a chronic relapsing condition. People often have to try several times before they're successful at being able to make this change for good. So the principles of the Ottawa model were very simple. And as I said, when we started initially, our intention was only to do a better job of this in our own hospital. So over time, though, we started to get asked about whether we could go to other hospitals and help them change their processes and practices as well. And that made us sit back down and think a little bit more about how do we get knowledge into practice in healthcare environments. And you've heard a lot about non-pharmacological interventions, but at the end of the day, this is really all about, can we transform the way that care is actually provided in some of the main delivery systems that we have? And of course, if we can embed that effectively, then we will be able to influence patients much more with the right kind of information. So we thought it was all about keeping calm and being systematic, and we wanted to look at processes that might make it easier for people to get interventions when they're in healthcare environments. So this really became a knowledge translation story, and although we didn't start with this intention, our program has now been spread across Canada, and it's reached in the past couple of years more than 350,000 smokers, and we're now in more than 400 sites across the country. So although we didn't follow models and we didn't set out to develop a knowledge translation and a really success story in this area, in fact, this is what's happened, and we have learned some lessons along the way. So I think one of the main insights that we had in looking at how do we help other organizations do this type of work was to recognize that when we're talking about the health outcomes that we hope that our patients can achieve, and of course we know there are many benefits to quitting, really the way that we're achieving that, though, is through the behavior of healthcare professionals. So this became a program that was not about how do we change smokers' behavior, but it became a program about how do we change the behaviors of healthcare professionals. And healthcare professionals are real people too, so they respond to some of the same kinds of things that other people do in terms of what determines their behavior. So something that really, I think, directed a lot of the work that we've done subsequent to that in deciding what the interventions should be at the organizational and also the healthcare professional level were a consideration of the predisposing, the enabling, and also the reinforcing factors that make it more or less likely that people will engage their patients in these types of behaviors. So we kind of sat down, and this was based on the original model by Larry Green, who was then at the University of British Columbia, one which is called Precede Proceed, but just really trying to look at, are there ways that we could make it more likely that staff would actually intervene? So we developed a 6-phase work process to actually take people through this and organizations through the process of transforming their practices when it comes to smoking cessation. This involved initially doing some introductory work with senior management to get buy-in from organization at the organization level, doing pre-program evaluation, then spending some time planning and putting in place a systematic protocol in these organizations. And that often meant that we needed to do policy change. And one of the key things about sustainable program change in big organizations is, can you change policy? And if you can change policy, you can probably make a program sustainable. At the end of the day, we would also, or just prior to implementing this program, we would also do a very intense training program for frontline staff, and then we would have implementation, but importantly, we would measure outcomes along the way and create a feedback loop so there would be continuous quality improvement in terms of their care for smokers in a particular hospital setting. So just to sort of summarize, what we have found is that in terms of organizational change, that it's important to be introducing what we call rules and tools. And that means being very organized and systematic about whose responsibility it is to do different kinds of actions within the healthcare environment. Also, we know in places like hospitals that they run on things on forms, and you have forms committees that you have to go through just to kind of change the kinds of questions that are being asked of patients. You need to be embedded in quality control tools like care maps and clinical pathways. You need to set up flow sheets so that people can remember the kinds of care that they're supposed to be providing. You need to have standard orders for medications so that people don't have to think about the kinds of medications that they're prescribing, but that they become second nature. I'm not sure if you're aware of the fact that the average physician, in fact, is only comfortable prescribing somewhere between 20 and 25 medications. So that if you take them out of their comfort zone and have them prescribe something new, they often are unsure about what they should do. So we try to make it easy for them to do that. So ultimately, you know your program is sustainable if it just becomes simply the way that things are done around here. And that's what we're striving for in the hospital setting. So really, in setting up a tobacco control protocol, we had to identify who was going to do the identification, when was that going to occur, where was it going to be documented, who was going to do the smoking cessation consult, and who was going to provide strategic advice and medication, who was going to engage people in follow-up, and then who would enter data. And these are all the specific behaviors. So again, it's taking the complex, what is really a complex intervention, and breaking it down into some very specific pieces. We've also evolved over the years very specific tools that can be utilized. We have patient education materials. We also have consult forms, standardized pre-printed scripts that can be used in terms of medication, and physician order sets that can be automatically implemented. We also provide feedback to organizations about how they're doing on their performance, because organizations are collections of individuals that ultimately respond to some of the same incentives and performance measurement and performance monitoring that individuals would also do. So people can see if their performance is getting better or in fact worse. When we did some of the initial analysis of the Ottawa model, we found that implementing the Ottawa model led to about an 11% increase in the long-term quit rates of patients that were coming through those particular hospitals that had implemented it. And of course, this was significant at a statistical level, but it was also clinically very important because it created many more thousands of quitters when you think about the number of smokers that pass through hospitals. I thought I'd just finish up today by talking to you about, as we've expanded the Ottawa model, we've moved to other outpatient environments as well. And so one of the most recent studies we've done is a cluster randomized trial that looks at putting smoking cessation into diabetes education programs in Ontario. And diabetes education is kind of interesting because diabetes and smoking go together. People who are smokers are more likely to develop diabetes or prediabetes. But ironically, the diabetes care system really pays almost no attention to smoking whatsoever. So we thought, can we actually introduce this? So this was the design here. We took 14 diabetes education programs in the province of Ontario, and this is a matched pair design. So we actually created pairs of all of those diabetes education programs, and within those pairs we assigned one to, they were randomly assigned to either the Ottawa model group or a waitlist control condition. There were seven programs in each of these, and then the Ottawa model group actually implemented the interventions that I've just discussed. And just as a reminder of those, again, it was going through and looking at who would be responsible for doing this, from the administrative staff to the diabetes educators, changing some of the forms that they were using in terms of admission, also setting up flow sheets with scripts so that people didn't have to remember what we wanted them to say, that they could simply look at their script and go from there. Putting in place standard orders, because these clinics are staffed primarily by nurses and dietitians, not by physicians, and then putting in place an easy to enroll in follow-up system. In terms of how it worked in terms of gathering data at the participant level, so new referrals to the diabetes education program were screened for smoking status by the administrator who was taking their call. Smokers were asked if they were interested in participating in a study about smoking cessation. These potential participants were then called by a research coordinator who got their consent verbally. And then they were contacted by telephone 1 week after their first scheduled visit to the diabetes education program to gather information on what the diabetes education program had provided to them in form of assistance for cessation. And then we followed up at 6 months to find out who was not smoking at that particular point in time. And if people said they weren't smoking, we then verified that using carbon monoxide. So I just wanted to highlight a couple of things. The first is that one of the things, because the Ottawa model is really a system-level intervention that's designed to change provider behavior, one of the first things that we wanted to do as a test really of our processes were to find out whether implementing the Ottawa model led to changes in the behaviors that patients reported their diabetes educator had done with them. So you can see that it didn't really create much change in terms of asking about smoking. People always are good at asking about smoking, but it really comes down to, do they actually provide assistance? And so if you're in the Ottawa model group, you are much more likely to be asked about your smoking, more likely to be offered assistance, more likely to be provided help to set a quit date, more likely to have discussed medications, more likely to have been provided with written materials, and more likely to have been scheduled for follow-up. So at the end of the day, we're really interested in are people quitting or not, and this is the impact of the implementation of diabetes education programs in terms of quit rates measured at 6-month follow-up. So overall, we had 314 smokers that were identified in these 14 diabetes education programs that participated in this. And you can see that the quit rate in the Ottawa model group was around 11% versus only about 2.6% in the waitlist control condition. These quit rates are not as high as what we typically see in hospital patients because it probably reflects a lower level of motivation on the part of the patient. But on the other hand, we see approximately the same magnitude of difference between the Ottawa model group and the control group as we saw when we were implementing in hospitals, even though the absolute quit rates in hospitals are much higher than they are in this particular outpatient environment. And that, again, is just comparing how we did in the diabetes education compared to hospitals. So just a few takeaway messages, and I know I've really just kind of maybe whetted your appetite for some of the work that's done in this area, but the Ottawa model has really become an example about knowledge translation, and this is really a critically important part of the whole scientific process about getting knowledge into action, and I think that there's a lot of important lessons that can be learned here. There are a lot of opportunities to learn about the best ways to implement interventions at scale, and I think one of the things that we've been able to achieve with this program is the ability to take it to a large number of organizations and to do so effectively. And finally, cluster randomized trials for us provide a certain way that we can evaluate these types of complex interventions that are implemented at an organizational level or a unit level or a program level in ways that can be useful in terms of building our knowledge base. I just show this as if any of this is of interest to you. This is our most recent paper on managing smoking cessation, which we published this past December in the Canadian Medical Association Journal. There's also a podcast that goes along with this, so if anybody has difficulty sleeping at any point in time, I highly suggest the podcast to you. It includes both myself as well as my colleague, Dr. Andrew Pipe. He's more of a booming voice and prone to histrionics, waves his arms around a lot, but I think you'll find that I'm the voice of reason on the podcast, and that perhaps you'll be able to take something from that. I want to thank you for your attention today, and thanks for coming out this morning. It's an early day, and I do appreciate it. We'll all go home in the same Uber. Thanks very much.
Thank you.